Welcome to the Deep Dive. Today, we're really getting into a crucial area for med-surg learners, dealing with patients who have problems with their sensory system.
That's right. We're zeroing in on the eyes and ears specifically, chapters 42 and 43.
Exactly. So our listeners looking to nail down the absolute must-know clinical info.
Yep. And our mission here is simple. Cut through the noise, pull out the core knowledge nuggets. We're talking pathophysiology, the why behind the problem, the risk factors you absolutely have to screen for, clinical signs, the things that tell you this is serious.
Right.
And most importantly, the nursing management. What do you do to keep patients safe and help them function?
Okay, before we dive into, the eyeball itself, let's set the stage. What's the big overarching concept for this whole unit?
Sensory perception. That's the key concept, tying it all together.
Sensory perception. Define that for us more.
It's basically the ability to take in information from your senses, see, hear, touch, whatever, and make sense of it. To interpret it and think about vision and hearing. They are just so vital for being independent, for communicating, for just basic safety, right?
Absolutely.
If someone's vision gets blurry or they can't hear well, their world literally shrinks. It gets riskier. Our job is to protect that.
That makes perfect sense. A great way to frame it. So let's start with chapter 42, the eyes, vision. You mentioned these structures can tell us about systemic health, too.
Oh, definitely. Changes in the eye can be the first sign of things like diabetes or hypertension. It's a window into the body, really.
All right, let's do a quick flyby of the eye's structure. 3 layers, right?
Yep, 3 main layers. You've got the outer tough one, the sclera, that's the white part, and its clear front window, the cornea.
Got it.
Then the middle layer, the uvea, that includes the iris, the colored part that controls how much light gets in, like the aperture on a camera.
And the inner layer, the retina. That's where the magic happens.
That's the command center for vision, yeah. The retina, it's lined with photoreceptors.
Rods and cones.
Exactly. Rods are for dim light, peripheral vision, seeing shapes in the dark. Cones need brighter light. They handle sharp central vision and all the color.
Okay.
So when we talk about diseases later, like glaucoma or macular degeneration, we're often talking about damage to these rods and cones. They're quite vulnerable.
Which brings us to something called intraocular pressure, IOP. Sounds important.
It's critically important. IOP is the pressure inside the eye, and it has to be kept just right. Think of it like air pressure in a tire.
Okay, so how is that pressure maintained?
It's a dynamic process. There's this fluid called aqueous humor. It's constantly being produced by a structure called the ciliary body, and it flows around the front part of the eye, providing nutrients, but then it has to drain out. It drains through this little network called the trabecular meshwork into the canal of Schlemm.
Canal of Schlemm. Okay, so
Yeah,
like a sink. Faucet's always dripping, drain has to keep up.
that's a perfect analogy. The ciliary body is the faucet, the canal of Schlemm is the drain. If that drain gets clogged or blocked,
Pressure builds up.
pressure builds up, exactly. And that increased IOP starts squeezing the tiny blood vessels in the retina and, crucially, the optic nerve fibers.
Ah, so that's glaucoma.
That's the mechanism of glaucoma.
Yeah.
The squeezing cuts off blood flow, leading to hypoxia, lack of oxygen.
Right.
And those nerve fibers and photoreceptors die, necrosis. And once they're gone, they're gone. That's permanent vision loss.
Wow. Okay, that really clarifies the danger of high IOP. Now, focusing the light itself, 4 functions involved.
Right. To get a clear image, the eye has to do 4 things. Refraction, which is just bending the light rays to focus them.
Okay.
Pupillary constriction and dilation, making the pupil smaller, miosis in bright light, or bigger, mydriasis in dim light.
Like adjusting the camera aperture.
Precisely. Then accommodation, which is the lens changing its shape, its curve, to focus on things up close. And finally, convergence, where both eyes turn slightly inward when you look at something really close.
Got it. So when refraction goes wrong, that's when you need glasses.
Usually, yes. If everything's perfect, that's called emetropia, perfect vision.
Emetropia.
But if your eyeball is maybe a bit too short or the lens doesn't bend light enough, the image tries to focus behind the retina. That's hyperopia.
Farsightedness. See far, struggle close up.
Exactly. And the opposite is myopia or nearsightedness. The eyeball might be too long or the light bends too much, so the image focuses in front of the retina.
Okay. Makes sense. Now, what about aging? What happens to the eye structure and function as we get older? Big changes.
Oh, definitely. Structurally, muscle tone around the eye can decrease. This can sometimes cause the lower eyelid to droop outwards. That's called ectropion.
And that causes.
Dry eye irritation because the tears don't spread properly. You also often see arcus senilis.
It's that whitish ring around the cornea. I've seen that.
Yep, a bluish-white ring. It's from fat deposits. Looks a bit alarming, but here's the key point for patients. Arcus senilis itself does not affect vision. You need to reassure them.
Good to know.
Yep.
And functionally. What's the big one?
The lens, it yellows a bit, it gets harder, and crucially, it loses its elasticity. It can't change shape as easily.
So, problems with accommodation.
Exactly. That loss of accommodation is called presbyopia. It's why older adults start holding menus or books farther and farther away to see them clearly. Near vision gets blurry.
Okay, let's move to our first big clinical example. Cataracts. Super common, right?
Incredibly common. It's the leading cause of reversible blindness worldwide. Basically, the lens gets cloudy, opaque, light can't get through clearly.
Like looking through a dirty window.
Kind of, yeah, or a foggy one. And age is the biggest risk factor by far. Over half of Americans have some cataract formation by age 75.
Wow.
But other things increase risk too. Trauma to the eye, long-term exposure to toxins or UV light.
Like sunlight.
Yep. Also smoking and definitely systemic diseases like diabetes and hypertension. They really accelerate cataract development.
So what does the patient actually notice? What are the symptoms?
Early on, it's subtle. Slightly blurred vision, maybe colors seem a bit faded or dull. Patients often say they feel like their glasses are just dirty all the time. As it gets worse, the blurring increases. They might see double. Difficulty with everyday things like reading signs or seeing faces clearly. And night driving becomes really tough because of glare from headlights.
Is it painful?
Generally, no. For typical age-related cataracts, there's no pain and no eye redness. If you see those, you need to think about other problems.
Okay. So if it's impacting their life, what's the fix?
Surgery is the only cure. The standard procedure now is amazing. It's called phacoemulsification.
Phacoemulsification. Break that down.
Sure. The surgeon makes a tiny, tiny incision. They insert this little probe that uses high-frequency sound waves ultrasound to break up the cloudy lens into tiny pieces.
Okay.
Then those little pieces are gently suctioned out. And right after that, they insert an artificial lens, an intraocular lens, or IOL.
And that IOL stays in.
Stays in permanently. Often, they can choose an IOL that corrects their distance vision, too, reducing the need for glasses afterwards, although most people still need reading glasses.
That's pretty incredible. But it's still surgery on the eye.
Yeah.
What's the biggest nursing priority afterwards?
Hands down, it's preventing any increase in intraocular pressure, that IOP we talked about.
Because the eye is healing, it's vulnerable.
Exactly. So we have to teach patients very specific activities to avoid. Think about Table 42.5 in the book. It lists things like bending over from the waist.
Right.
Lifting anything heavy. The rule of thumb is usually nothing over 10 pounds. For context, a gallon of milk is about 8 to 9 pounds.
Okay, good reference.
Also avoiding sneezing, coughing forcefully, blowing your nose hard, straining during a bowel movement, anything that makes you bear down.
The Valsalva maneuver increases pressure in the head and eyes.
Precisely. And wearing tight shirt collars can even contribute. So coaching is key.
What if someone has, say, chronic constipation or bad allergies? Things that make straining or sneezing likely.
Great question. That's where proactive nursing comes in. We anticipate those issues. We make sure they're on stool softeners before surgery, maybe suggest antihistamines or cough suppressants if appropriate. We have to minimize those risks.
And what's the big red flag post-op? What tells you something's wrong?
There's a critical action alert here. The patient must report immediately if they experience any decrease in vision compared to how it was right after surgery, or if they develop significant eye pain, especially if it comes with nausea or vomiting.
Why nausea vomiting?
That specific combination, sharp pain plus nausea vomiting, is a classic sign of a sudden, dangerous spike in IOP, or possibly even bleeding inside the eye. That's an emergency. Call the surgeon immediately.
Okay, shifting gears from the cloudy lens of cataracts to the silent pressure of glaucoma. You said this causes permanent damage.
Yes, irreversible vision loss. Glaucoma isn't one single disease. It's a group of disorders where that increased IOP damages the optic nerve.
And the damage starts where?
Typically, it starts in the peripheral vision and slowly works its way inward. That's why it's so insidious. People often don't notice until significant permanent damage has already occurred.
Scary. What's the most common type?
Primary open-angle glaucoma, or POAG, accounts for maybe 90% of cases.
Open angle. So the drain isn't physically blocked shut.
Right, the angle between the iris and the cornea is open, looks normal, but the drain itself, that trabecular meshwork leading to the canal of Schlemm, it's just not draining efficiently. It's like a partially clogged pipe.
So the fluid backs up slowly.
Slowly, gradually. IOP is typically elevated maybe in the 22 to 32 millimeter Hg range. Normal is around 10-21. It develops over years, often with no early symptoms.
So what are the late symptoms then?
Patients might eventually notice foggy vision, maybe a mild ache in their eyes. Seeing halos around lights is a common complaint. And then the hallmark, loss of peripheral vision, tunnel vision, essentially.
Okay, that sounds bad enough. But there's an emergency type too.
Yes. Primary angle closure glaucoma, or PANSI-G. This one is a physical blockage.
What happens?
The iris actually pushes forward and physically closes off the angle, completely blocking the aqueous humor from reaching the drain. It's like slamming a door shut.
So the pressure spikes.
Dramatically and suddenly. IOP can shoot up above even 50 millimeter Hg or higher. This is an absolute ocular emergency.
The symptoms reflect that urgency.
Oh, yeah. Sudden, severe, excruciating eye pain, often with blurred vision, headache, nausea, vomiting, and the eye looks red. Needs immediate treatment to lower the pressure and prevent total blindness.
Okay, patchy G is the emergency. For the much more common POAG, what's the management strategy?
Since it's chronic, management is lifelong. The main goal is controlling the IOP to prevent further nerve damage, and the cornerstone is usually eye drop medications.
What do the drops do?
They work in one of two main ways. Either they decrease the production of aqueous humor, turning down the faucet, or they increase the outflow or absorption, unclogging the drain.
Gotcha. Any really key teaching points for patients using these drops? Besides just remembering to use them.
Oh, absolutely. Critical teaching points. First, if they're using more than one type of glaucoma drop, they need to wait 5 to 10 minutes between drops.
Why the wait?
So the first drop isn't immediately washed out or diluted by the second one. You need to give each one time to be absorbed.
Makes sense. What else?
The second thing, and this is huge for safety, is teaching punctal occlusion. You can picture it from figure 42.18 in the text.
Punctal occlusion, explain that.
After putting the drop in the eye, the patient needs to apply gentle pressure with their finger right against the inner corner of the eye, near the nose, where the tear duct is, and hold that pressure for about a minute.
Why is that so important? Life-saving, you said earlier.
Because that tear duct drains directly into the nasal passages and then into the systemic circulation. Without blocking it, the eye drop medicine can get absorbed into the bloodstream.
And that's bad.
It can be very bad, especially with certain types of drops like beta blockers. Timolol is a common one. If that gets absorbed systemically, it can slow the heart rate way down, lower blood pressure, and critically cause bronchospasm or worsen asthma or COPD.
Wow. So blocking that duct keeps the medicine localized in the eye where it's needed.
Exactly. Minimizes systemic side effects. It's a non-negotiable teaching point for patient safety.
Okay. And if drops aren't enough to control the IOP and POA?
Then surgical options come into play. Laser trabeculoplasty is common, using a laser to basically open up the clogged drainage channels.
That's invasive.
Relatively. If that doesn't work or isn't suitable, they might do a trabeculectomy, which involves creating a whole new drainage channel for the fluid to escape the eye.
More involved surgery.
Yes. And again, post-op care focuses on preventing infection and, you guessed it, avoiding increases in IOP. Hashtag tag 1.4, other key eye disorders.
All right, let's touch on a few other important eye conditions. What about problems with the cornea, that clear front window?
Yeah, a couple things there. Keratoconus is where the cornea actually loses its normal shape and starts to bulge outward like a cone, distorting vision. Keratitis is inflammation or infection of the cornea.
Okay.
But the really urgent one is a corneal abrasion, a scratch, or especially a corneal ulceration. That's considered an emergency.
Why is a scratch an emergency? Seems minor.
Because the cornea has no blood vessels of its own, it gets oxygen directly from the air and nutrients from the aqueous humor.
Right, you mentioned that, a vascular.
So if there's a break in the surface, like an abrasion or ulcer, bacteria can get in, and the body has a very hard time fighting that infection off without a direct blood supply. It can spread incredibly fast, cause scarring, and lead to permanent vision loss within days if not treated aggressively with antibiotics.
Okay, that makes sense. And if the cornea gets scarred or damaged beyond repair?
Then a corneal transplant or keratoplasty might be needed, replacing the damaged cornea with healthy donor tissue.
And post-op for a transplant? Same IOP concerns.
Yes, definitely avoid increasing IOP. Same rules as cataract surgery apply. But there's an added major concern: Graft rejection.
The body attacking the donor tissue.
Exactly. We have to teach patients to watch for signs daily. Things like redness, cloudiness, pain, or decreased vision, especially starting near the edge of the graft and moving inwards. Rejection can happen weeks, months, even years later, so vigilance is key.
Got it. Let's move deeper to the retina. Age-related macular degeneration, AMD. You said this is a huge cause of blindness in older adults.
It's the leading cause of irreversible blindness for people over 65 in developed countries. It specifically affects the macula, the part of the retina responsible for sharp central vision.
So it hits reading, recognizing faces.
Exactly. All the detailed tasks. There are two main types: dry AMD and wet AMD.
Dry AMD.
That's the more common form, maybe 80–90% of cases. It involves the slow breakdown of light-sensitive cells in the macula, often due to blockage of tiny retinal capillaries over time. It progresses gradually.
Risk factors.
Age is the biggest, but smoking is a huge one. Also hypertension, family history. For dry AMD, management focuses on slowing progression. Things like high-dose antioxidant vitamins, specifically lutein and zeaxanthin.
Found in leafy greens.
Yep, leafy greens, colorful vegetables. Encouraging that diet is important.
And wet AMD.
Less common, but much more aggressive. This is where abnormal, leaky blood vessels start growing underneath the macula.
Leaky means fluid and blood.
Yes, they leak fluid and blood, which damages the macula rapidly. Vision loss can be sudden and severe.
Is there treatment for wet AMD?
Yes, thankfully. The main treatments involve injecting medications directly into the eye, anti-VEGF drugs. VEGF stands for vascular endothelial growth factor. These drugs help stop those abnormal blood vessels from growing and leaking. Laser therapy can sometimes be used too.
Okay. Now for the really dramatic retinal emergency. Retinal detachment. What is the patient experience?
This is usually sudden and painless. That's key, no pain.
Okay.
Patients often report seeing sudden bright flashes of light. We call that photopsia.
Photopsia.
Or a shower of floaters, little dark spots drifting in their vision. But the classic, unmistakable sign is the sensation of a curtain or a shadow being pulled over part of their field of vision.
A curtain being pulled. That's the one to remember.
Absolutely. That means a part of the retina has peeled away from the back wall of the eye, losing its blood supply. It's an emergency requiring surgical repair.
And the surgery often involves something called a scleral buckle.
Right. Scleral buckling is one common repair method. They basically sew a small silicone band, the buckle, onto the outside of the sclera, the white part of the eye. This gently pushes the wall of the eye inward, bringing it closer to the detached retina, helping it reattach. They also often use laser or cryotherapy, freezing, to seal the tear that caused the detachment.
And post-op care.
Very important. Often involves specific head positioning to keep the retina in place while it heals. And again, strict avoidance of activities that increase IOP or cause jarring head movements.
Before we leave the eye, trauma. What's the one absolute rule if something is sticking out of the eye?
Do not remove it, ever.
Okay.
Doesn't matter how small it looks, that object might be plugging a hole, holding the structures together. Pulling it out could cause the contents of the eye to extrude. It must only be removed by an eye specialist, usually in the operating room. Stabilize it, shield the eye, and get them to emergency care.
Crystal clear. And for chemical splashes?
Immediate, copious irrigation. That's the priority. Use sterile saline or even tap water if that's all you have. Hold the eye open and flush continuously, aiming the stream from the inner corner towards the outer corner for at least 15–20 minutes, maybe longer, while checking the pH. Get the chemical out.
Okay, let's switch senses. Time to tune into the ears, chapter 43, starting with the external ear.
Right, the part you can see the pinna or auricle and the ear canal leading inward. Its main job is just collecting sound waves and funneling them towards the eardrum.
And the canal makes earwax, ceramin.
Yep, ceramin is protective. It lubricates the canal and helps trap dust and debris. Now, here's a really interesting clinical pearl about the external ear. Embryologically, the outer ear develops at the exact same time from the same tissues as the kidneys and urinary tract.
Really?
Yeah, so if you see a baby born with significant deformities of the external ear, maybe it's misshapen or low set, that should be a flag to also check carefully for potential kidney or urinary tract abnormalities. It's a known association.
Wow, that's fascinating. Okay, moving inward, past the canal, we hit the eardrum.
The tympanic membrane, yeah. It separates the external ear from the middle ear. When you look with an otoscope, it should be thin, translucent, kind of a pearly gray color.
And behind that is the middle ear, tiny bones in there.
Yep. The middle ear is an air-filled space containing the 3 smallest bones in the body. the malleus, incisius, and stapes, often called the hammer, anvil, and stirrup. They transmit vibrations from the eardrum to the inner ear.
And that space connects to the throat.
Through the eustachian tube. That's vital for equalizing pressure. You know when your ears pop on an airplane? That's the eustachian tube opening to balance the pressure inside your middle ear with the cabin pressure.
Got it. Deeper still, the inner ear.
That's where the real processing happens. It houses the cochlea, which looks like a tiny snail shell. Inside the cochlea are specialized hair cells that vibrate in response to sound. Those vibrations get turned into electrical nerve impulses that travel along the auditory nerve, cranial nerve 8 to the brain, where they're interpreted as sound. The inner ear also contains the structures for balance, the semicircular canals, and the vestibule.
Complex system. Does aging hit the ears hard too?
Oh, yes. Age-related hearing loss is called presbycusis.
Presbycusis. Is that like cataracts for the ears?
In a way, yes, it's very common. It's a type of sensorineural hearing loss, meaning the damage is in the inner ear or the nerve pathway, usually due to degeneration of those cochlear nerve cells over time.
And how does it usually manifest? What sounds are hardest to hear?
Typically, it affects the ability to hear high-frequency sounds first.
High frequency, like high-pitched sounds.
Exactly. Think about consonant sounds in speech, sounds like f's, ses, takey, fe. Those are higher frequency.
So they might hear vowel sounds okay, but miss the consonants that give words clarity.
Precisely. That's why speech sounds muffled or mumbled to them. They hear that someone is talking, but they can't easily understand what is being said, especially in noisy environments. It's incredibly frustrating and isolating for them.
I can imagine. Any structural changes with aging too?
Yeah, the hairs in the ear canal can become coarser and thicker, and the cerumen tends to get drier and harder, making impaction more likely.
Okay, let's clarify the different types of hearing loss. There's conductive loss.
Right. Conductive hearing loss means there's a problem conducting the sound waves through the outer or middle ear. It's a mechanical blockage issue.
Like what?
Could be something simple like impacted cerumen or a foreign object stuck in the canal, or maybe a perforated eardrum or fluid buildup in the middle ear from an infection, or even otosclerosis, where those tiny middle ear bones fuse together and can't vibrate properly.
And the key thing about conductive loss is?
It's often correctable. If you remove the wax, treat the infection, or surgically fix the eardrum or bones, the hearing can potentially return to normal.
How do these patients typically behave?
Interestingly, they often speak softly because their own voice sounds loud to them through bone conduction. And sometimes they report hearing better in noisy places.
Better in noise. That seems counterintuitive.
Yeah, it's thought that the background noise makes other people speak louder, which helps overcome the conductive block. It's called the paracusis of Willis sometimes.
Okay, so that's conductive. What's the other main type?
Sensorineural hearing loss. This is damage to the inner ear, the cochlea, those delicate hair cells, or to the auditory nerve, sienna 8 itself.
So the problem isn't getting sound to the inner ear, it's processing it in the inner ear, or sending the signal to the brain.
Exactly. And this type is usually permanent.
What causes sensorineural loss?
The biggest cause is probably prolonged exposure to loud noise. Think construction workers, musicians, factory workers. It's cumulative damage over time. Aging itself, presbycusis, is another major cause. And then there are ototoxic drugs. This is critical for nurses to know.
Ototoxic, meaning toxic to the ear.
Yes. Certain medications can damage those inner ear hair cells. Key classes to watch out for are aminoglycoside antibiotics like gentamicin or tobramycin.
Okay.
High doses of loop diuretics, especially IV furosemide given too quickly.
Lasix.
Right. Also some chemotherapy drugs like cisplatin, and even high doses of aspirin or quinine.
So we need to be aware of that risk when administering these.
Absolutely. Monitor hearing function, watch for tinnitus.
And how do patients with sensorineural loss present? Opposite of conductive.
Pretty much. They often speak loudly because they can't hear their own voice well. They struggle immensely in noisy environments because their damaged inner ear can't filter out background sounds effectively. And tinnitus, that ringing or buzzing sound, is very common.
Okay, how do we actually measure or diagnose the hearing loss?
The gold standard test is audiometry.
Audiometry.
This is done by an audiologist in a soundproof booth. They test the patient's ability to hear different frequencies measured in hertz, hertzeric, that's the pitch, and different intensities, measured in decibels, dB, that's the loudness.
So it gives you a precise map of their hearing ability.
Exactly. It tells you the type of loss, conductive, sensorineural, or mixed, the degree of loss, mild, moderate, severe, profound, and which frequencies are affected. For reference, normal speech is around 60 dB. Someone with severe loss might only start hearing sounds above 80 or 90 dB.
Got it. Any other tests used?
Tympanometry can check middle ear function, like how well the eardrum moves. Electron sphygmography, or ENG, looks at inner ear function related to balance by tracking eye movements.
Okay. Now, an important safety point about just looking in the ear.
Yes, a crucial nursing safety alert. You should not attempt an otoscopic examination looking in the ear canal with an otoscope on a patient who is confused, agitated, or can't hold their head still reliably.
Why not?
Because if they suddenly move while the speculum is in their ear, you could easily scratch the canal or even perforate the eardrum. Safety first. You might need assistance or have to defer that part of the exam until it's safe. #tag 2.3 Management and Assistive Devices.
So when we're caring for someone with hearing loss,
Mhm.
how can we communicate most effectively? It's got to be a priority.
Absolutely. It's about safety, dignity, everything. The Best Practice Guide gives great tips. First, make sure you have their attention before speaking.
Get face-to-face.
Yes, face them directly in a well-lit room so they can see your lips and expressions. Reduce background noise as much as possible. Turn off the TV or radio.
Okay.
Speak clearly and at a moderate pace. And here's a key point. Don't shout.
Don't shout. Why not? Seems like making it louder would help.
Shouting actually tends to raise the pitch of your voice, making those high-frequency consonant sounds even harder for someone with presbycusis to distinguish. It just distorts the speech. Use a normal tone. Just articulate clearly.
Good tip. What else?
Use short sentences. Rephrase if they don't understand. Use gestures. Have paper and pencil ready for writing key information if needed. And of course, utilize qualified interpreters for sign language like ASL if that's their primary mode of communication.
Great strategies. What about devices? Hearing aids are common.
Yes, hearing aids are the most common assistive device. They're basically miniature amplifiers.
Do they work for everyone?
They tend to be most helpful for people with conductive hearing loss because they just need to make the sound louder to get past the blockage. They can help with sensorineural loss too, but maybe less effectively, especially if speech discrimination is poor. They can make sounds louder, but not necessarily clearer if the nerve pathway is damaged.
Okay. What's involved in hearing aid care? What do patients need to know?
Meticulous care is important. Keep them dry, take them out before showering or swimming, clean them regularly, especially the ear mold, to remove wax and debris. Check the batteries frequently and have spares. And a really practical tip, avoid spraying hairspray or perfume while wearing them, as the mist can clog the microphone opening. Put the aids in after using those products.
Good advice.
Yeah.
Are there other devices besides standard hearing aids?
Yes. For profound sensorineural deafness, cochlear implants are an option. They bypass the damaged hair cells and directly stimulate the auditory nerve. There are also newer, totally implanted devices available now, like the Esteem system.
Okay, and let's revisit that safety warning about ear cleaning.
Worth repeating because people do it all the time. Patients should never stick anything smaller than their own fingertip into their ear canal.
So no cotton swabs.
Definitely no cotton swabs. They just push wax deeper, risk impacting it against the eardrum, or can cause scratches or even perforate the eardrum. Same goes for hairpins, keys, toothpicks. Nothing smaller than your fingertip should go in the canal. #tag 2.4 infections and specialized inner ear disorders.
All right, let's talk about ear infections. Otitis media, that's the middle ear, right?
Correct. Infection or inflammation of that air-filled space behind the eardrum. We talk about acute otitis media, which is sudden onset, usually lasts less than 3 weeks.
Painful.
Oh, yeah. Acute often has intense throbbing ear pain. Also, maybe some conductive hearing loss because of fluid buildup, maybe a low-pitched tinnitus or humming sound, sometimes dizziness or fever.
Okay.
Then there's chronic otitis media, which is longer lasting or recurrent. This can lead to permanent changes like perforation of the eardrum or scarring.
How are these treated?
Acute bacterial infections usually need systemic antibiotics. Sometimes, if the eardrum is bulging and painful from fluid pressure, the doctor might do a myringotomy.
Myringotomy.
It's a tiny surgical slit in the eardrum to allow the fluid to drain out and relieve the pressure.
Yeah.
For chronic drainage issues, they might insert a tiny tube called a grommet or PE tube through the eardrum to keep the middle ear ventilated long term. You can see a picture of that in figure 43.2.
Okay. What about infections of the outer ear canal? Swimmer's ear.
That's external otitis. It's an infection or inflammation of the skin lining the ear canal. Often happens when water gets trapped in the ear after swimming, creating a moist environment for bacteria or fungi to grow.
What are the signs of that?
The hallmark is pain, especially when you touch or move the outer ear, the pinna, or press on that little cartilage flap in front, the tragus. They might also feel like their ear is plugged or full.
Then treatment.
Usual involves carefully cleaning the canal to remove debris, followed by topical antibiotic or steroid ear drops. Sometimes applying gentle heat can help with the pain. And importantly, the patient needs to keep the ear completely dry, avoid swimming, using earplugs or earbuds, or even hearing aids in that ear for about 7 to 10 days while it heals.
Got it. Keep it dry. Now, back to impacted wax, or maybe a kid sticking something in their ear. How do we get things out?
For impacted ceramin, softening agents like D-Brox or just mineral oil drops can help loosen it first. Gentle irrigation with warm water can sometimes flush it out.
But you mentioned a huge safety warning about irrigation earlier.
Yes, 2 critical contraindications. Do not irrigate if you know or suspect the eardrum is perforated. You'll force fluid and potentially bacteria into the middle ear space.
Okay, rule 1.
Rule 2. Do not irrigate if the foreign object is vegetable matter like a bean, a pea, a popcorn kernel.
Why not vegetable matter?
Because it will absorb the water, swell up, and become even more tightly lodged, making removal much harder and potentially causing more trauma. Those need to be removed carefully with instruments, usually by a specialist.
Good to know. What about mastoiditis? Sounds serious.
It is very serious. The mastoid is the bone behind the ear, and it has air cells connected to the middle ear. Mastoiditis is an infection of those air cells, usually spreading from an untreated or inadequately treated middle ear infection.
What are the signs?
Pain, tenderness, and swelling right behind the ear. The skin might be red. Sometimes the ear itself gets pushed sideways or downwards by the swelling. Fever, headache.
Why is it so dangerous?
Because those infected mastoid air cells are separated from the brain by only a thin plate of bone. The infection can easily spread, causing complications like meningitis, brain abscess, facial nerve paralysis. It's a true emergency.
So treatment needs to be aggressive.
Absolutely. High-dose 5E antibiotics immediately. Often requires surgical drainage, maybe even a mastoidectomy, where they have to remove the infected bone tissue. You don't mess around with mastoiditis.
Okay, let's finish with a couple of specific inner ear disorders. Meniere's disease, you said it has a classic triad of symptoms.
Yes. Meniere's is defined by 3 core symptoms that usually come in episodes or attacks. 1, severe episodic vertigo, a spinning sensation. 2, tinnitus, often a roaring or low-pitched hum. And 3, fluctuating one-sided sensorineural hearing loss.
Vertigo, tinnitus, and hearing loss, usually on one side. What causes it?
It's thought to be caused by an excess buildup of fluid called endolymph within the labyrinth of the inner ear. This distends the structures and messes up both hearing and balance signals. It's called endolymphatic hydrops.
Sounds debilitating during an attack.
It really is. The vertigo can be so intense, patients are unable to stand or walk, often accompanied by nausea and vomiting. The hearing loss can fluctuate, sometimes improving between attacks, but often worsening over time.
How is it managed?
A lot of it is lifestyle management initially. Reducing sodium intake is key, as salt affects fluid balance. Also, limiting caffeine, nicotine, alcohol, and MSG, as these can be triggers for some people.
Okay.
During an attack, medications like diuretics might be used to reduce fluid volume, and vestibular suppressants like meclizine or diazepam can help with the vertigo and nausea. Patients need strict fall precautions during attacks and should learn to move their heads slowly.
Is there a surgical fix?
There are options, but they're often reserved for severe disabling cases because some are destructive. For instance, a labyrinthectomy involves removing the labyrinth on the affected side. It cures the vertigo, but results in total permanent hearing loss in that ear, so it's a significant trade-off.
Definitely a last resort. Okay, one last one. Acoustic neuroma.
This is a benign tumor, meaning non-cancerous, that grows on the vestibulocochlear nerve, cranial nerve 8. That's the nerve bundle carrying both hearing and balance information from the inner ear to the brain.
Benign, but its location sounds problematic.
Exactly. As it slowly grows, it compresses the nerve. Symptoms usually develop gradually. Tinnitus is often the first sign, followed by progressive, one-sided sensorineural hearing loss, and sometimes mild intermittent vertigo or balance issues.
How's it diagnosed and treated?
Diagnosis usually requires an MRI scan. Treatment depends on the size of the tumor, the patient's age and health, and the severity of symptoms. Options include just monitoring it if it's small and slow-growing, stereotactic radiation therapy, or surgical removal. Surgery carries risks to hearing and facial nerve function due to the tumor's location. #outro. So we've covered a huge amount of ground today, really digging into the core issues of the sensory system unit eyes and ears, from controlling that delicate pressure inside the
The
eye
IOP, yeah.
to understanding how a cloudy lens causes cataracts and the different ways hearing can be lost. The connection is always between the anatomy, the physiology, and how it impacts a patient's ability to perceive their world.
Absolutely. And for you, the listener, the big takeaways really center on recognizing those urgent situations. For the eyes, remember the signs of retinal detachment, those sudden flashes, floaters, the curtain.
Right. And the sudden severe pain of angle closure glaucoma. Contrast that with the slower changes of cataracts or open angle glaucoma.
And for the ears, it's those crucial safety rules. Punctal occlusion for eye drops to prevent systemic effects.
So important.
Knowing the difference between conductive and sensorineural loss so you can communicate effectively.
And recognizing that infections like mastoiditis aren't just earaches, they're emergencies because of where they can spread.
So mastering this content isn't just about passing an exam. It's about understanding the day-to-day reality for patients living with sensory loss. Think about how much we rely on sight and sound for independence, for identity.
It's profound.
Your role as a nurse goes way beyond just the technical skills. It's about that careful teaching, making sure they're safe, and connecting them with resources, support groups, rehab services that help them stay engaged with life despite these challenges.
That connection is vital. Well, thank you for joining us on this really intensive exploration of sensory problems. We genuinely hope this synthesis helps solidify your understanding and boosts your confidence out there in clinical practice.
From the Last Minute Lecture team, thanks so much for listening. We'll catch you on the next deep dive.